Welcome you all. Today we discuss the pharmacotherapy of Parkinsonism. Parkinsonism is a neurodegenerative disorder characterized by tremors, rigidity, and bradykinesia. Normally, there is a balance between dopamine and acetylcholine in the brain. Normally, there is a balance between dopamine and acetylcholine in the brain. But what happened in the Parkinsonism? In Parkinsonism, there is degeneration of dopaminergic neurons, which leads to decrease in dopamine level in the brain. So our aim of the therapy is to restore the balance between dopamine and acetylcholine. This is the classification of drug used for the treatment of Parkinsonism. First group is drugs which increase dopamine level, which includes levodopa and carbidopa, COMT inhibitors which includes entacapone and tolcapone, and NMDA receptor antagonists which includes amantadine. Second group is drugs which inhibit dopamine metabolism, which includes MAO inhibiting drugs. These are silicilin and rasagiline. Third group is drugs which directly stimulate dopamine receptors. It includes ergot derivative bromocriptine and cabergoline, and non-ergot derivative which includes pramipexole, propinenolone, and corticosteroid. So this is a diagram by which we try to understand how different drugs act on the Parkinsonism. So first and most important drug is levodopa. Levodopa is a dopamine precursor drug. It is rapidly converted into dopamine, both peripherally as well as centrally, and produces beneficial effect. But the problem with levodopa is in periphery it is mainly metabolized by dopa decarboxylase enzyme, and only less amount of levodopa crosses the blood-brain barrier. To inhibit this peripheral dopa decarboxylase enzyme, we combine carbidopa. Carbidopa inhibits this enzyme and increases the penetration of levodopa across the blood-brain barrier. It decreases the peripheral side effect of levodopa. Levodopa is also metabolized by COMT enzyme into 3-O-methyl-dopa. So here we use COMT enzyme inhibitor entacapone and tolcapone. Both the drug increases the efficacy of levodopa. Levodopa crosses the blood-brain barrier, reaches the dopaminergic neuron, converted into dopamine, and produces beneficial effect. Dopamine inside the dopaminergic neuron converted into dopa-C by MAO enzyme. So here we use MAO enzyme inhibiting drugs, silicilin. This dopamine is released from the dopaminergic neuron and act on D2 receptors. So here we use dopamine receptor agonistic drug like bromocriptine, cabergoline, pramipexole, and propinenolone. After release of dopamine, also it gets metabolized by COMT enzyme into 3-O-methyl-dopa. Here we use centrally COMT enzyme inhibitor drug tolcapone. Levodopa is associated with certain adverse effects. First adverse effect is nausea and vomiting, because levodopa converted into dopamine, and dopamine activates the dopamine receptor present in the CTJ, and stimulation of CTJ produces nausea and vomiting. For levodopa induced nausea and vomiting, we use domperidone. Next adverse effect is dyskinesia. Dyskinesia is abnormal choreoform movement of face, trunk, and limbs. For the treatment of dyskinesia, amantadine, which is an NMDA receptor antagonist, can be added. Next adverse effect of levodopa is on-off phenomena. On-off phenomena occurs due to fluctuation in levodopa response. Levodopa has shorter plasma half-life, which is responsible for on-off phenomena. In on state, patient enjoys normal motility, but in off state, Patient is unable to raise from a chair in which he has sat down a few minutes ago. For treatment of on a phenomena, COMT inhibitor like entacapone and tolcapone can be beneficial. Levodopa is also associated with certain cardiovascular adverse effects like tachycardia, palpitation, and can precipitate arrhythmia. Levodopa, when used for prolonged period of time, can produces or can precipitate schizophrenia. And for treatment of schizophrenia, we can use atypical antipsychotic drug. Recently, a new drug, pimavanserin, is approved for levodopa-induced psychosis.